Okay, we are live and welcome to another episode of Machine Medicine's interview series concerning all things neuromodulatory. And we're delighted to have Laura Cabrera here with us today. Laura, thank you so much for joining and agreeing to talk about this interesting slant on deep brain stimulation. Usually we're talking about the technical or the clinical aspects of it, but today we're going to take a more ethical and philosophical approach, which I'm delighted to do. And but perhaps you would be so kind as to start off by giving us a short introduction to yourself and how you came to write this paper in this area and your sort of academic and or other background more generally.
Yeah, well, first of all, thank you for the kind invitation. It's a pleasure to be here. I actually have what I consider an interesting background because I started as an engineer. So my bachelor was in electrical and communication engineering.
Really?
While I was doing those studies, I always thought, well, we create this great technology, but we rarely stop and think about what are the implications to individuals and society. So that really led me to dive into applied ethics. So I did a master in applied ethics and I did a PhD in applied ethics. And in the path of doing that, I was really always interested in technology. So my interest started with nanotechnology, then I really moved to neurotechnology. And since then, that's what I've been doing. So now, currently, I'm an associate professor in neuroethics at Penn State in the Department of Engineering, Science, and Mechanics. And my main research deals with the ethical social implications of neurotechnology. And so that's really what has led me to write around different issues that happen with neurotechnology, from implantables like deep brain stimulation to other like non-implantables like transcranial magnetic stimulation or other similar.
Fascinating. That's really, really interesting. So an engineer that's transitioned to the sort of philosophical and ethical. So perhaps we could, before we dive into the nitty gritty, we could talk a little bit about neuroethics, because it's a relatively new area of philosophy, right? And it'd be interesting to sort of understand your perspective on why neuroethics has emerged in what would it be like? I don't know when the first papers were written around it or the phrase was coined. Perhaps you could tell us that. How old is it as a field, and why did it come into existence, and why do you think we need it?
Yeah, absolutely. So it's interesting. I mean, in relative terms, it is new, certainly. But I mean, we've started doing work. By we, I mean the field, since probably then 1992. I think some papers started to coin the term neuroethics. And then in 2002, if I remember correctly, there was a big conference that really bring together the first cohort of people interested in the field. And that's kind of was a catalyzer of the field. And so we've been about like more than 20 years. The field also had a very important moment when the International Neuroethics Society was created in 2006. So again, I think there's many years in the making since, publishing papers, creating a society that was focusing in the field. Now we have journals that's the focus, neuroethics. And so that means to say that we have bioethics before neuroethics, right? But I think the field of neuroethics really started from the pressing need of, okay, we have now more technologies and ways in which we are understanding the brain, changing the brain, and perhaps we need a field that really allows us to focus more intensely in those areas. And so a lot of people would say, well, neuroethics is really not a unique field, it's just a subfield of bioethics. Others would disagree, but I think we at least can agree that the brain and the nervous system and intervening in them does create issues that are pressing in ways that perhaps when we intervene in other organs is not. So therefore, the field of neuroethics and in my view, it's a very fascinating field to be involved.
No, absolutely, and quite right. Although it is 20 years old, so 2 decades, but the sort of the history of philosophy goes back at least 2.5 millennia back to the Milesian philosophers. So it's 2 orders of magnitude younger than a lot of areas, right? So that's fascinating. And then you mentioned that yeah, some of the reasons why it's sort of come into existence. For example, we now understand a lot more about the brain, and perhaps indeed can intervene and manipulate it in certain respects, and perhaps there is an obvious sense in which one could do that in a non-benign way, in a malignant fashion. But I'm also interested that you said that you in particular work in applied neuroethics, because one of the areas I would have thought is, well, obviously as we learn more about the brain, then it would have big implications for things like philosophical debates on, freedom, or does it really exist, or are we deterministic creatures? But you're more interested, I take it, or please do contradict me if this is wrong, but you're more interested in the sort of the applied ethics. And does that mean in the sense of what are the sort of day-to-day implications and decisions that we need to take around actual devices being deployed into actual people?
So, I mean, when I say apply, it's just so philosophy is a very big umbrella, an area of study, and then within philosophy you have ethics. So apply ethics just basically is ethics that really focus applied to a field, right? So you could do ethics where you just discuss moral theory, but apply ethics really deals with, like, for example, bioethics applies moral theory to ethical issues in the life sciences. So in this case, neuroethics is apply ethics because it applies moral theory into the area of the brain sciences. And so now when we talk about neuroethics, there's different flavors of it. And that's what I really love the field, because you have neuroethicists that will be very much, philosophers that will be debating and discussing issues about, how does these technologies affect agency or identity from a very philosophical point of view, primarily, right? Very theoretical. But there are others that are more practical. And I think that's, so I started more in like just the normative discussion. That's how I started. But then I moved more towards a more empirical, practical. So a lot of my current research, I do empirical work, which means I do interviews, focus groups, surveys, where I really try to understand different public's perceptions or concerns, beliefs around neurotechnologies. And now, not all neuroethicists do that, but I think the field really enables for a variety of people, or a variety of neuroethicists doing and using different tools to get at different issues in the field.
And from the look of your paper, from reading it, it looks like you're more than even doing empirical work. You're not just doing qualitative empirical work. You're trying to do quantitative. Is that right?
Yeah. So I like using kind of mixed methodologies. So the paper that we're discussing here today is actually the result. It started first with interviews. So a more qualitative work that really allows us to explore, what are the issues, what are the themes, and that informed the survey that this paper is based on. Okay,
well, let's get into the nuts and bolts of that then. Perhaps you'd like to sort of set up the premise behind this paper and mention about, perhaps a few words about the debate in the field about whether or not people should be receiving DBS earlier on. There have been some clinical trials with, promising results, perhaps not completely knocked down, but certainly interesting results suggesting it might be a sensible thing to do. Would you say a few words about the sort of the assumptions and premises behind this paper?
Yeah, so this paper is very much focused on the use of deep brain stimulation, shorthand for DBS, in Parkinson. So now DBS is being tried in other disorders. So I think it's approved for epilepsy, dystonia, tremor. It's experimental trials for depression, OCD, anxiety, anorexia. So again, the field of how we use neuromodulation is very broad, and depending on which disorder you decide to focus on, it might come with different ethical issues, different concerns. The science is it's in different stages. So I think we have to be careful when we talk about DBS in the field and really contextualize it to the area. So this paper is very much focused on DBS for Parkinson. Now, DBS for Parkinson has been used for many decades now. We have thousands of patients around the world that use DBS for Parkinson. So that means that we have moved from thinking that DBS is a last resort treatment to really we use it now, 3-4 years after someone is diagnosed. So this paper really started when I learned from one of my neurology colleagues that there is a group in the US that is really trying to push this idea that if we start DBS for Parkinson really early in the progression of the disease, we'll be able to deter that progression. So it would be disease changing or disease modifying. Now, I was initially, obviously there's some level of, oh, that would be great for people. But then the more I did research and the more I talked to my colleagues, it turns out that, there are many issues that we have to overcome before we really push it that early. And so really this paper started from the question of, how early is too early, right? So we don't want it to be offered as a last resort because we know that by then many patients don't actually have the benefit from it. But there's also probably a time when too early could also be it could be lead to bad things rather than good things. And so we try to explore first, as I said, with interviews and then with the survey, different groups of stakeholders involved. So I think this paper is specifically focusing on patients, both patients that have had DBS and patients who haven't had DBS, and trying to explore when it would be too early for them to have DBS. So what would be their concerns and what would be their expectations that they have? So that's the premise of this paper.
Okay. And what would you say to someone that said, well, they should just listen to their doctor because he or she is the expert, and when he or she says it's the right time, then that's when it's the right time?
Well, this is interesting. I think that's a very paternalistic way of thinking about how medical decisions should be made. And I think in the field of bioethics and neuroethics, there's this idea that this type of really hard decisions should be shared decision. So that is the term shared decision making, right? Where the physician should engage with the patient, the caregiver, in trying to, okay, let's explore what do you value in your life? What preferences you have? And would this treatment really allow you to achieve, your values and preferences or not? So a classical example in DBS for Parkinson is this academic, I think from Germany, who have Parkinson and he had DBS. And as a side effect of the DBS, he had a speech slur. So his speech would be slurred by the device. And being an academic, he really enjoyed, being able to talk to people. And so he couldn't really teach the way he used to. And so he wrote a book saying, like, if I have known about this, I probably would have not want to have DBS. Right. And so again, it kind of just makes us realize that for some patients, this might not be the solution, right? And I think we need to explore what might be potential side effects. Sometimes those side effects, we can modulate depending on, reducing stimulation or changing the lead. So now we have ways in which we can actually try to overcome some of these side effects. But again, that's just to say that patients sometimes are not fully informed of what can be side effects, what could be the results of having DBS for too long in their life. That's also something that we're starting to get better grasp of. And so these decisions of should I get DBS and when should I get it in the course of my disease should be decisions that should truly involve the patient, the clinician. And something that we argue in our paper is that probably a good way to do this is engaging prospective patients with patients who already have DBS, because that could help leverage the expectations, right? A clinician knows from the scientific literature, the side effects and the benefits. But really, those that already have gone through DBS are the experts in living with DBS. And so we argue that there's a good group in which, and some clinics already do this, they pair patients. But we argue that this is a strong way in which they can really benefit in leveraging their expectations and maybe better understanding what can go wrong that is not always there in the literature, or clinicians might not think it's relevant.
Yeah, or the clinician just passes over it. It can cause changes in your speech, but it doesn't happen in the majority of cases without sort of saying, well, the speech could actually make you sound like you're a bit drunk the whole time and stop you from speaking properly at academic forums and that kind of stuff. So, but it almost sounds like the ideal that you're aiming for is not really shared decision making, but actually whereby the clinician is merely acting as a source of information, and other patients are acting as a source of information. And really, what you're driving at is patient-based decision making, right? The patient as the primary and perhaps even principal agent, the only agent in the decision. Is that, or is that not a fair characterization?
It's not, because so for example, it could be that the patient says, I want to have DBS, but the clinician knows based on, let's say, on the genetic makeup of the patient that maybe this is not the right thing to do. So then the patient, the clinician could still say, I'm not gonna, let you go with this. I mean, you're free to go with someone else if they want to do it, but based on, what I believe this could harm you, and, explain the reasons. The physician still holds some level of, decision. So that's why it's still shared.
Even if it's only kind of withholding the option. But yeah, okay, makes some sense. And then you mentioned already that actually it could have kind of this kind of perspective can have practical implications, whereby you don't just have a conversation with your clinician, but you are introduced to other people that have had this kind of intervention, this kind of therapy, and you can talk to them about how it went. I presume there's online resources that serve that as well. I mean, there are Facebook groups and that kind of stuff. Does that sort of meet some of these requirements, or not really? Is this something that needs a formal kind of realization in sort of clinical workflows?
I think, we people come in we have different preferences. And I think for some patients, the Facebook groups or social media groups are the right forum because they might feel more comfortable with those groups. For other old-fashioned group people like myself, I think I cherish like more in-person conversations. And so perhaps, and I know some clinics too, they have like this monthly get together with patients that want to come and share their experiences. So I think those could be really powerful venues to engage. So I don't think I'm arguing like we should only do this and not the social ones. I think we should allow for as many different venues for people to share and to learn from each other.
Right. Okay. So perhaps we can get into the sort of the methodology and conclusions of your paper. You mentioned that it was largely sort of questionnaire based. I believe you did it online. Is that right? And used a few things like the Michael J. Fox Foundation and the American Parkinson's Association in order to recruit. And so what happened for these patients? How were they found, and and then what happened to them, and then what was the outcome? What were your conclusions?
So as you mentioned, we use the Michael J. Fox and the Parkinson Foundation to reach out. So they have newsletters that they help distribute the survey. The Michael J. Fox Foundation has a clinical trial kind of section. And so this wasn't a clinical trial in the sense that, was an intervention, but the patients could still find it, read about it, and if they were interested, could click. So that's how we recruited. And as I mentioned, we recruited both patients who have had DBS and patients who haven't had DBS.
Right.
They took the survey online. And then all the data was anonymized. We analyzed the data. We actually were very fortunate to have two students from Cornell that were really interested in the project, and they helped with the analysis of the data. Basically, this data set led to, I believe, at least two papers. In this paper of the shared decision making, we were really trying to compare the two type of patients, those that already have and those that haven't, with the hypothesis that perhaps those that already have had DBS might have different views on how early would be too early versus those that haven't. What we found is actually for both groups, there's this idea that there's kind of a half. So half within one group would say, I would go for early if I could, if I have had the chance. And the other half would say, I think I got it when it was the right time for me. I wouldn't have done it earlier. And so there's this, and the concerns are very similar in patients that have had DBS and patients that haven't had DBS. So
yeah,
I mean,
so I was wondering about that selection. So the can you repeat what the hypothesis was, that there would be differences between the two
for this
groups?
particular paper, we were really interested to see whether having had DBS make any difference in terms of the concerns that patients might have, or desires to have DBS earlier.
So I was wondering about that. Weren't you concerned about the kind of the possible confounder that maybe DBS people have, maybe people have had DBS because they're already different, not the DBS has made them.
It's actually interesting, because I mean that could have been a potential, something that we've seen in the data. But when you look at the data, even people who have had DBS, there's a very kind of, as I say, almost half of patients who said, I got it when it was the right time. I wouldn't have not have it earlier. And then the other half was like, oh no, if the doctor had told me, I would have done it earlier for sure. So and the type of concerns are just very similar. So I think some patients that already have DBS, they tend to be, and there's literature about it that said that some DBS patients tend to be more risk prone. So they kind of are okay with taking risks. And those might be the ones that are more likely to try to go and get it earlier than not.
Right.
But then you have the type of patients that said, this is brain surgery. I don't take this lightly. I'm only going to go through when it's really the last thing I can do. I'm going to try everything else before I go through brain surgery. And this type of concerns, again, were very similar both in groups that have had DBS and have not had DBS. So I think obviously we need to, when people say, oh, DBS is just going to continue exploring. So I think that people still have a lot of concerns about intervening in the brain in such an invasive way. So we're still going to need to work with that. And I think, obviously we can do more education to patients and things like that, but we also need to be respectful of, where might be the values and preferences. Perhaps people feel that the medications are still handling their symptoms okay, and they don't feel the need to have surgery. For others, they might say, look, I don't even want to deal with the potential side effects of medication. Those, I'm going to have the surgery now. Now, science, we continue finding new things, and it might be that we find out that the current medications we have are actually doing harm in the long term, and therefore maybe we should start offering DBS earlier. I mean, that's still, we don't know. But again, there's a lot of scientific studies trying to understand what are the long terms of levodopa in patients.
Yeah, it is very interesting. And I was at a conference a few months ago, and there was somebody talking about using high frequency ultrasound to treat tremor, I think, versus using deep brain stimulation to treat tremor. And it was very interesting hearing him talking about how often enthusiastic patients are about high frequency ultrasound over deep brain stimulation, even though deep brain stimulation is sort of officially reversible. They are still sticking a wire into your head, but people often say it's reversible because you can take the wire out. Whereas high frequency ultrasound, if the lesion is irreversible, and yet because it doesn't involve actual neurosurgery, just sitting in a big machine, there's no blood, there's no cutting, there's nothing like that. Often people are much more enthusiastic about high frequency ultrasound. So yeah, it is important and interesting to take those perspectives into account. Was there anything in this paper that surprised you in the results? Was it?
I think I just would. I mean, with the interview, we got a little bit of this half, but I never thought that in the survey that was gonna kind of be replicated. That it truly it was a half. So, and we tried to use some of the sociodemographics to understand whether there might be something there that maybe people with more education might be more likely to. I think education was a little bit a predictor there, but it was the only one. Like, and that really surprised me. You know that.
So education predicted that they would have surgery or more concerns, or
That they were more likely to have surgery earlier,
right. I see. Okay. Yeah.
or want to have surgery earlier.
Right. Okay. So in a way, your null hypothesis was that there's no difference between the two groups was preserved, right? Is that right? It's like
Yeah, the concerns. I think we found that. I think perhaps in the risks, there were some differences in terms of how, on the magnitude of how the risks are perceived.
yeah.
But overall, the trend was that it was their main concern. It's just that the magnitude of the perception was different among the groups. So yeah, no. The one interesting thing that requires a follow up is that. So these were surveys that we conducted, and when this was a voluntary thing from patients wanting to do the survey, but we really didn't have any medical information about, have they been good responders with DBS, what are their symptoms. So, I mean, a more rigorous study now would have to include perhaps being able to look at their charts, look at their scales, because all of this is self-perceived. Like, yes, I'm doing perfectly with DBS, but now we'll have to do a comparison with, okay, what your clinical chart is telling us, how are your scales looking, and then be able to compare.
Yeah. It's very interesting because when people a fashionable topic nowadays is precision medicine, and of course in the field of neuromodulation we have big opportunities. But one, there's enormous heterogeneity of patients, but also the devices are often highly configurable and can be programmed with multiple different settings, as you're no doubt aware. And deep brain stimulation, typically these systems have can have hundreds of millions of different possible parameter settings. So there's enormous opportunity for personalizing these therapies to individuals. But one interesting aspect that seems to emerge from your work and perhaps related work is that actually another thing that needs to be personalized is the therapy to the preferences of the individual, so that you could have two individuals who were being offered exactly the same therapy and have exactly the same disease and are in exactly the same disease state, but yet need to be personalized in quite a different way because their things like their risk appetite or their risk aversion are quite different.
Yeah, I mean, that's the idea of this shared decision making. And again, in many places, this is something that is how things are done. They truly try to involve the patient in understanding, what's going to happen and things like that. But in my interviews, I also had kind of neurosurgeons or neurologists tell me, well, we have this, DBS group, we make the decision, and then we just present it to patients. So it was very, very little input from the patient in terms, what are their values and preferences. So yeah, hopefully, as we continue in the field, there will be more awareness of the importance to really include the patient's values and preferences, and even the caregiver in Parkinson's, especially late state. The caregiver plays a very important role in people's lives. So truly also understanding, the dynamics and the values as a couple is important in making this type of decision.
Right. And do you think there are many sort of, you can obviously sort of try and educate clinicians and train them to stuff to take these things into account. Are there many tools that facilitate this kind of thing, or could there be tools that would facilitate this kind of thing? I imagine, that in Parkinson's disease, for example, there are some standard assessments which are done prior to DBS, like the Part 3 motor assessment, or a mock cognitive assessment, a speech assessment, and so forth. So, should we be including a sort of a profile of the patient's kind of values and concerns as a sort of standard assessment that's being done that could then be included in the MDT meeting when those neurosurgeons and neurologists are making a decision about a patient? Is this something? Are there
Yeah,
the tools exist to do this, or must they be invented yet?
I mean, this is interesting. That's why neuroethics is an interdisciplinary field, and we should certainly do a little bit more in exploring different stakeholders, because obviously my interviews and survey touch on neurologists and neurosurgeons, but social workers probably play a big role. They have very important conversations with patients in terms of, the resources they have, where they live. And so they
Mm,
might already have some questions that might elicit some of these important areas for us to explore. And so the question that I don't have an answer, because I haven't interviewed really social workers, is how much of that input is really funneled into the larger decision making of let's do this or not.
mm,
But I mean, certainly, I think the idea of having more tools of how to help clinicians and neurologists, neurosurgeons, and others involved in the decision to elicit these values in a more
mm.
standardized way, I think would be relevant. To my knowledge, there isn't, but I really haven't really explored too deeply in this area. But one thing that my group is trying to do next is try to develop a decision aid for patients in making decisions not only about DBS, but really currently for Parkinson, there is a big spectrum of potential therapies that a patient can undertake. And so really trying to help patients navigate these, vast kind of different opportunities will be important. And as we teach them of, you have the possibility to do a levodopa pump, or you have this other medication, or you have DBS, or you have ultrasound, really walk them through, what might be the risk, what might be the benefits, and by integrating their values and preferences, help them make a decision that might align with their values and preferences.
Fantastic. All right. Well, Laura, look, I'm conscious we come to the end of our allotted time. It's been a great pleasure and a privilege to have you here to talk to us about your research, and certainly sowed several seeds in my mind to think about, and will do. And I would love to chat to you again about it sometime. Perhaps we can do that offline. But yeah, thanks very much for your time, and we'll follow your future work with great interest.